Welcome back to The Explainer. So today we're tackling something that, let's be honest, usually strikes total fear into the hearts of medical students and junior doctors: medical shock. But we're doing things differently today. We're completely ditching those massive textbook tables and the endless rote memorization. Instead, we're going to build an intuitive, visual framework. We're demystifying all these complex hemodynamics by using a really simple concept: the plumbing metaphor.
Look, the absolute biggest mistake you can make with a crashing patient or, a really tricky board question is just instantly guessing the diagnosis. Don't do it. Instead, you got to follow this golden rule. Learn the pattern first, then the causes. Recognizing that underlying hemodynamic pattern, that is absolutely the secret to mastering shock.
Here is our roadmap. We're going to start with the 4 core patterns of shock, move right into the big picture of hemodynamics, and then we'll set up 2 major showdowns: hypovolemic versus cardiogenic, and obstructive versus distributive. Finally, we'll wrap the whole thing up with the ultimate exam approach. Let's get into it.
Section 1. The 4 patterns of shock.
Okay, to lower the cognitive load here, we're going to look at the human cardiovascular system exactly like the plumbing in your house. Think about it. For plumbing to work, you need fluid, a pump to move that fluid, clear pathways, and pipes that hold the right amount of pressure. When shock happens, there is a catastrophic failure in one of these 4 areas. It's basically like finding a burst pipe in your basement, but obviously with way higher stakes. An empty tank is hypovolemic shock. If you have a failing pump, well, that's cardiogenic shock. If something is actively blocking the flow, that's obstructive. And if your pipes are inappropriately dilated and just losing all their pressure, that is distributive shock.
Let's break down what those 4 failures actually look like in the real world. First up, hypovolemic shock literally means volume loss. Think severe hemorrhage or massive burns. Your biggest bedside clue? Low jugular venous pressure, or JVP, simply because the tank is empty. Next, cardiogenic shock. Here, the pump is failing. The heart itself is the issue, maybe from a massive MI. So fluid backs up, leading to pulmonary edema and a high JVP. Then we have obstructive shock. The pump works perfectly fine, but the flow is blocked. Something like a pulmonary embolism is stopping the blood from moving forward. Again, fluid backs up, so you get a high JVP. Finally, distributive shock. The tank, pump, and flow are all totally fine, but the pipes have lost their tone. You have low systemic vascular resistance, massive vasodilation, which we often see in sepsis or anaphylaxis. The huge clue here? Warm extremities early on, because those blood vessels are flushed and wide open.
Moving on to Section 2. Hemodynamics, the big picture.
So, looking at the hemodynamic dashboard, there's a super fascinating trend across the first 3 types of shock. In hypovolemic, cardiogenic, and obstructive shock, your systemic vascular resistance, or SVR, goes up. It's basically the body panicking, squeezing the hoses to maintain blood pressure for your brain and your heart. But distributive shock is the total rebel here. In distributive shock, SVR is down. The body desperately wants to squeeze those hoses, but it literally can't because inflammatory mediators, say from a massive infection or an allergic reaction, are forcing the pipes wide open. Interestingly, this is also the only shock where cardiac output might actually go up early on, as the heart beats frantically just trying to fill those massive dilated pipes.
Now, if all those hemodynamic details felt like a bit much, here is the ultimate cheat code. You can actually use the physical exam to shortcut the hemodynamics. Start by looking right at the neck veins. High JVP instantly points you to a backup problem, so you're thinking cardiogenic or obstructive shock. Low JVP points you to an empty or totally expanded system, meaning hypovolemic or distributive shock. You literally cut your differential diagnosis in half just by glancing at the patient's neck.
Section 3. Hypovolemic versus cardiogenic shock.
This right here is the foundational difference between simply needing to add more fluid to a system and needing to fix the motor itself. On one hand, you have the empty tank. The solution? Fill it up. On the other hand, you have the broken pump. And listen, giving a broken pump more fluid is actually going to make the backup infinitely worse.
It's amazing how clearly these 2 emergencies separate at the bedside. With hypovolemic shock, the core problem is intravascular volume loss. Your exam clues are going to be flat neck veins, tachycardia, and distinctly cool, clammy skin. Why? Because that SVR is sky high, clamping down on blood vessels in the skin to save the core organs. Your first move is to fill the tank. Pump in IV fluids or blood. But compare that to cardiogenic shock. The main problem is a failing pump. You still have that dangerous low blood pressure, but the clues are totally different. Now you're hearing crackles in the lungs from pulmonary edema, and you're seeing high JVP. The tank is full, but the pump just can't clear it out. So your first moves have to be different. You treat the underlying MI, You very carefully manage fluids and use pressors or inotropes to help that heart squeeze.
Section 4. Obstructive versus distributive shock.
Let's compare the blocked flow of obstructive shock with the dilated pipes of distributive shock. These two present fundamentally opposite responses when it comes to systemic vascular resistance. In obstructive shock, the body's SVR acts exactly how you'd expect. It clamps down hard. But in distributive shock, that total loss of SVR is the actual core problem. Walking through the specific clues for these two. With obstructive shock, you have impaired cardiac filling or outflow. Classic culprits here are a massive PE, cardiac tamponade, or a tension pneumothorax. The clues you're looking for are highly mechanical. You'll see high JVP, sure, but you might also find muffled heart sounds in tamponade or completely absent breath sounds on one side with a tension pneumothorax. The fix? You have to relieve the obstruction immediately with a needle or targeted therapy. Now flip over to distributive shock. The problem is massive vasodilation and capillary leak, mostly from sepsis or anaphylaxis. The exam clues are really unique here. You'll feel warm extremities early on, maybe they have a fever if they're septic, or wheezing and hives if it's anaphylaxis. The hemodynamics are going to show that massive drop in SVR. So your first move is giving fluids to fill those newly widened pipes, pushing vasopressors to literally squeeze them shut, and of course, fixing the underlying root cause with antibiotics or epinephrine.
Section 5. The ultimate exam approach.
Okay, memorizing this exact 4-step framework is absolutely crucial. When the pressure drops and the ICU alarms start blaring, you do not panic. Step 1, recognize the state of shock. Low blood pressure, poor perfusion. Step 2, immediately check the JVP, the lungs, and the skin. These physical signs are your diagnostic compass. Step 3, use those exact clues to match the plumbing mechanism. Is it the tank, the pump, the flow, or the pipes? Only then, at step 4, do you lock in your specific diagnosis and treat the cause fast.
So let's tie it all together with a rapid review. I want you to lock these mental hooks into your brain right now. An empty tank means hypovolemic. A broken pump means cardiogenic. A clogged pipe is obstructive, and a splitting hose is distributive. Just remember the golden rule. Pattern first, bedside clues second, cause-specific treatment third.
And that brings us to the end of this explainer. By swapping out all that stressful rote memorization for a truly intuitive understanding of the body's plumbing, you now have a rock-solid framework you can rely on in the absolute highest pressure situations. So I'm going to leave you with this final thought for your next clinical shift or board exam. When that alarm sounds and the pressure drops, are you going to waste vital seconds blindly guessing the exact cause? Or will you look at the patient's skin and neck veins to instantly decode the pattern? Keep this framework in your back pocket and you'll always know exactly what to do. Thanks so much for joining me on this explainer, and keep focused out there.